Hi Naresh.
Yeah. Hi, sir.
Hi Naresh.
Yeah, hi, sir. Give me a moment, sir. Give me a moment.
No problem. பிரசன்டேஷன்ல
சார்
ஸ்ரீதரா சம்பத்தா?
ஸ்ரீராம் தான் சார், டாக்டர் ஸ்ரீராம் ஃப்ரம் சென்னை சார். அவர் மட்டும் சடனா கேஸ்க்கு பிரைமரி கேஸ் போயிட்டாருங்க சார்.
சரிடா, ஓகே.
மட்டும் நீங்க அப்டேட் சும்மா சொல்லிக்கிட்டாங்க சார், மேனேஜ் பண்ணிக்கிறேன்
அது எத்தனாவது பிரசன்டர் அவரு?
சார் அவர் வந்து 11:35 தான் சார். 1 2 3 4 ஃபிஃப்த் பிரசன்டேஷன் தான் சார்.
சரி, அப்ப எடுத்து விட்டுலாம், நோ ப்ராப்ளம். வந்தாருன்னா பண்ணிட்டோம், இல்லாட்டி எடுத்து விட்டுரும்.
சும்மா ஒரு வார்த்தைக்கு சொல்றதுனால நம்ம சொல்லி மேனேஜ் பண்ணிக்கலாம்.
அது ஒன்றும் ப்ராப்ளம் இல்லைடா, பார்த்துக்கலாம். சொல்டா லிபின்.
மொத்தம் 6 பேஷண்ட் இருக்காங்க சார்.
சரிடா,
வார்ட்ல இந்த சரவண தர்மராஜ் இருக்காங்க சார். பிசிஏ பண்ணி தேர்ட் பிஓடி சார். இன்னைக்கு
சரிடா,
ஸ்டேபிளா இருக்காங்க சார். டிஸ்சார்ஜ் பண்ணலாமா சார் இன்னைக்கு?
பண்ணிடலாம்டா.
ஓகே சார். அப்புறம் இந்த அமுதா பேஷண்ட் சார், பிஎம்ஐ பண்ணவங்க சார். அவங்களுக்கு டிசி மட்டும் நேற்று வரைக்கும் 25,400 இருந்துச்சு. இன்னைக்கு ஒரு டிசி பார்க்க சொல்லியிருக்கேன் சார். ஃபீவர் எதுவுமே கிடையாது சார். ஒரு இச்சிங் மட்டும் உடம்பு ஃபுல்லா சொல்றாங்க சார். இது ஊதுற மாதிரி இருக்கு அப்படிங்கிற மாதிரி சொல்றாங்க. எதுவும் ஸ்கின் டாக்டர் எதுவும் பார்க்கலாமாங்கிற மாதிரி கேட்டாங்க சார்.
எவ்வளோ இருக்கு டோட்டல் கவுண்ட்டு?
இன்னைக்கு நேற்று வந்து 25,400 சார். இன்னைக்கு பார்க்கல, ரிப்பீட் பண்ண சொல்லியிருக்கேன் சார் நான்.
ஃபீவரே கிடையாதோ?
இல்ல, இந்த ஃபீவர் நைட்ல இருந்து இப்போ வரைக்கும் ஃபீவர் கிடையாது.
மோனோசெஃப் தானே கிடைக்குது?
ஆமா சார், மோனோசெஃப் தான் சார்.
சரிடா, நம்ம பிஜிஸ் இல்லை நம்ம தாமஸ் யாராவது ஒருத்தர் ஒரு தடவை பார்க்க சொல்லிடு. எங்கே இருக்காங்க பேஷண்ட்டு? சரி, வார்டில் பார்க்க சொல்லியிருப்பாங்க.
டிஸ்சார்ஜ் இன்னைக்கு மாத்திரம் கேட்டாங்க இன்னைக்கு.
இன்னைக்கு அது காப்பீடுனால இன்னைக்கு பண்ண மாட்டாங்க, நாளைக்கு தான் பண்ணுவாங்க.
ஓகே சார், ஓகே சார், ஓகே சார். சார் அப்புறம் ஸ்ரீனிவாசன் சார், பிபிசி பண்ண தேர்ட் பிஓடி சார். அவங்களும் நல்லா ஸ்டேபிளா இருக்காங்க சார்.
சரிடா, ஓகே. டிஸ்சார்ஜ் பண்ணிடுறியா? பண்ணிடலாம்டா.
ஓகே சார். அப்புறம் சிஎஸ் 3ல சார் அந்த சுல்தான் இப்ராஹிம் சார், நேற்று பிடிசி எல்ஏடி பண்ணுவாங்க சார். நார்மல் மட்டும் 2.5 மைக்ஸ் போயிட்டு சார்.
சரி, அப்படியே கண்டினியூ பண்ணு. சரி,
ஓகே சார். இப்போ சிஎஸ்சி 2ல சார் அந்த கணேசன் பேஷண்ட் சிடிஎஸ் பேக்கேஜ்ல அமிச்சிட்டா சார். இன்னைக்கு மோஸ்ட்லி சிடிஎஸ் வார்டு மாத்திர மாதிரி இருக்கும் சார்.
சரிடா, ஓகே
சார். அப்புறம் அந்த கிருஷ்ணசாமி பேஷண்ட் சார், அவங்க நேற்று ஈவினிங் போல எல்லாம் வில்லிங் சொன்னாங்க சார், லேபரட்டோமி எல்லாம் பண்றதுக்காக. பேஷண்ட்டுக்கு நேற்றுல இருந்து அவுட்புட் இல்லை சார். நேற்று கிரியேட் 3.6 இருந்தது, இன்னைக்கு 5.6 இருக்கு சார். நம்ம அவுட்புட்ல ஆர்டில் எல்லாம் போட்டு மானிட்டர் பண்ணிட்டு இருக்கோம் சார்.
அது ஃபீமரல் லைன் இருக்கா? எடுத்துட்டாங்களா?
நீங்க சார் எடுக்கிறாங்க, ஷீட் எடுக்கிறாங்க சார்.
ஷீட் எடுத்துட சொல்லி, எடுத்து கம்ப்ரெஷன் பண்ண சொல்லிடு.
ஓகே சார், அரவிந்த் சார் கேஸ் பார்த்துட்டு இருக்காங்க சார்.
சரி, ஓகே. பார்த்துட்டு ஷீட் எடுக்க சொல்லிடலாம்.
ஓகே சார், ஓகே சார். சார் அவ்வளோதான் சார், நான் கேட்டு பார்ப்போம்.
சரிடா, இது 2 கேஸு. அந்த இவர் பேர் என்ன இப்போ கடைசியாக சொன்னீங்க? இப்போ கிருஷ்ணசாமி அமுதா 2 மட்டும் நம்ம பிஜிசி இல்லை தாமஸை பார்க்க சொல்லு. மிச்செல்லாம் டிஸ்சார்ஜ் பண்ணிடலாம்.
ஓகே சார். அமுதா பேஷண்ட்டுக்கு டெர்மட்டாலஜி சார் பார்த்ததுக்கு அப்புறம் ஓகே வாங்கினா போதும்ல சார்?
அது நாளைக்கு தான், இன்னைக்கு டிஸ்சார்ஜ் கிடையாது, காப்பி இருந்தால.
ஓகே ஓகே.
சரி,
தேங்க்யூ.
Good morning, sir.
Good morning, Adarsh. Good morning.
Hi, sir. எங்க சார் பாம்பேயா சார்?
ஆமாப்பா சிக் இது நிக்கு மீட்டிங்ல இருக்கேன்.
ஓகே 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 சரி சார். ரைட் ஃபைன் சார்.
எஸ் ஆதர்ஷ் எப்படி போயிட்டு இருக்கு அப்புறம்?
கோயிங் ஆன் சார், சேம் ரொட்டீன்.
Hello? Hello? Hello?
Hi, sir. Good morning, sir.
Good morning, good morning.
Sir, actually, this link, as you know, that this link is only for faculty
Faculty.
members. Yeah.
Okay.
Yes. Simultaneously, we can't be able to see the number of participants here, sir.
Okay.
So whatever questions they have been shared, we will share with here, sir. Actually.
Sadish, sorry, sir, one of the faculty, he is the panelist.
Yes. Only faculty, speakers, and moderator. This link will be accessible for participants. There will be some other link, same link,
Yeah.
but we can't be able to see the participants.
Yeah. That is anyway. That is done. Okay.
Good morning, Elilan sir.
Yeah, good morning. Good morning.
Good morning, sir. Nice seeing you.
எப்படி இருக்கீங்க செல்வமணி சார்?
As usual, sir. Going on.
When did you return from NIC?
I'm still in NIC only.
Oh, yeah.
I'm still at Bombay only, sir.
Oh, right.
Yeah. Leaving today afternoon.
Today, right.
Yes, sir.
Good morning, sir.
Hi, good morning. எப்படி இருக்கீங்க?
சார்.
Fine. அப்புறம் ஆதர்ஷ்,
அப்புறம் சார்,
how is life?
life is going on. திண்டுக்கல் வடமலையான் சார்.
Oh.
Adarsh is doing very well there. Dindukal, Vadamalayan. He is in our native place only. My native is Dindukal only. Yes, Dindukal. So he's doing a good job there.
He is a triple product.
Yeah. We are all in the same institution. No?
Yeah.
So but he is doing a lot of exercise, losing weight.
Oh.
In other.
That's why he's taking it.
More than interventions, taking care of myself.
So I think it is time now, exactly 10:30.
Huh.
So if the organizers, Satish, somebody, are you there on the line?
Yes, sir. Myself, Vignesh and Satish both are there, sir. So once you inform, sir, we will start the recording also, sir.
Yeah, I think you can start the recording. We'll go with the first presentation.
Yes, sir.
Because we'll have to finish in time. After that, each one of us have a lot of them. Otherwise, my flight will go.
Yes, sir. Recording started, sir.
Okay.
So I'll start sharing my screen.
Yes, sir, please. And at the outset, I thank the organizers for calling us here and have a good discussion. And we have very expert speaker, Ellen sir, and my own colleague, Dr. Sampath, and Dr. Mahadev and Vijin Joseph, Sriram and Pankaj. So we hope that we'll have good learning from each one of us here. And Adarsh, I just missed your name. Adarsh is also here. I think we'll have a good discussion and go ahead with this. I think with this, I will request Dr. Elilan sir, you go ahead with your presentation.
Yeah, my screen is visible.
Yeah, we can see your name. Make it full screen, sir.
Yeah. Okay. So this case I just read yesterday. I returned from NIC on Friday, and Saturday morning I had kept this case. So this was a 76-year-old gentleman, diabetic and hypertensive with dyslipidemia. He had a PTCA done to mid-LAD 6 years back. He was fine for 4 years. Then from 2 years, he started having chronic coronary syndrome. At that time itself, RCA had lesion borderline 50-60%, so nothing was done. Now CAG done revealed a patent LAD stent. His RCA was superdominant RCA, tortuous, heavily calcified, and with multiple nodules seen in angiogram itself. His ejection fraction was normal, and his renal function also was normal for his age, creatinine of 1.2 and eGFR of 63. So this is the baseline coronary angiogram. You can see the artery tortuous in the proximal segment. You can appreciate the thick calcific nodule, the proximal segments, and another 2 nodules in the mid segment itself. The mid segment was very tight. So the RCA was a huge RCA supplying a large territory, tortuous also, and heavily calcified. So the patient, this angio was done outside, and patient was advised, was given both options, PCI and CABG. Then patient came to me. So I said, I mean, generally for when his LAD state was patent, nothing was needed for the left system. So we don't send for surgery usually for right alone, but this is a large RCA. So I think PCI would be a little complicated, but can be done. Cost will be high because you will need debulking devices. But surgical option is also there, told. So initially they wanted surgery, but then they
Sir,
changed their
can you
mind.
run the other angio also?
Yeah. Then they changed their mind, and then they wanted PCI. So this angio was done here. So after angio, we knew wiring itself could be challenging, because at the mid segment, it was almost like 99% occlusion. So patient was hydrated well with NS 100 ml 4 hours before the procedure. Bronac 600 video was given. We took a right common femoral access with micropuncture, and then a right comoral vein also taken for TPI. A left common access was kept for IABP backup in case placed for better support, and a balloon flotation TPI was placed in IVC, not in the RV. Now, as said, challenges started during the wiring itself. First, we thought we'll take a fine cross microcatheter with the Asahi Scion blue wire. The initial lesion itself took some time to cross. Then finally, we managed to cross. And then when we were trying to negotiate the mid lesion, the wire got damaged and deformed. So then we had to change that fielder wire to a fielder XT, sorry, the cyan blue wire to a fielder XT wire. And then somehow we could manage to go across the lesion and park it distally. What we thought will cross with the fine cross microcatheter after the wire crossing, but the microcatheter could not cross. So then we thought we'll wedge it at the mid lesion and then try to pass the rotawire. So we had decided by this time that rota has to be done since it was not crossable with a microcatheter. But when we wedged it and tried to pass the rotawire, it could not go. Probably it was changing and the catheter was inside a hard chunk of calcium, wire could not cross. So then what we thought, we'll better pre-dilate it a little so that we create space. So then we passed a 1 mm Rayuri balloon and dilated at that balloon was crossable. We dilated the mid portion. And then after that, the microcatheter could be crossed. So then the microcatheter was parked distally. And then the rotawire was placed inside. And then we started doing rotablation. We were a little careful because of the tortuosity in the proximal RCA.
Yeah.
Rota runs at 160 to 190 in the proximal lesion. Mid lesion, it took some time. It was not crossing easily, but then somehow we managed to cross even the mid lesion and burr the mid one. So then successful rotablation was done. Then this is the check shot after the rotablation. You could still see heavy calcium in the mid and proximal segment. During rota, patient developed chest pain and ST segment elevation in inferior leads. Intracoronary nicotindyle was given. Even now, OCT catheter could not be crossed. We thought we'll do an imaging to see how much we have debulked, but OCT catheter did not cross. So hence, again, microcatheter was taken in over the rotawire and the rota. So we thought we'll do a orbital atherectomy. We had two choices. Either we do orbital atherectomy or we can do IVL balloon, but we were doubtful whether the IVL balloon, the artery size was 3.5, whether a 3.5 IVL balloon can cross. So we thought we'll go with the orbital atherectomy. So the rotawire was exchanged for Viper flex wire. And then orbital atherectomy was done. Initially, we thought the proximal lesion, since it was near the osteoproximal, and there was a little tortuosity, we thought we'll do retrograde sanding for the proximal RCA lesion. So when we tried to cross that, we actually crossed the mid lesion also. So we did retrograde sanding for the mid lesion. Initially, we did it at 80K. And after 2-3 rounds, we had ablated well. And then we retrograde the proximal lesion also was done. And then again, both lesions we did at 120K also because the vessel size was large. Again, patient developed chest pain and ST elevation. This time we had to give him fentanyl 30 mg and morphine 4 mg to elevate his pain. But after that, we could successfully do orbital atherectomy also for the patient. And then this is the check shot post orbital atherectomy. Now you could see substantial gain in lumen, but we are still not happy. We thought we'll do imaging. And this is the imaging post rota and orbital atherectomy. You can see the heavily calcified vessels, the calcium nodules, and you can see good cuts done by the rota and orbital atherectomy. You can see the deep cuts made by the double atherectomy done to him. So then we thought we'll do a cutting balloon also since we are not satisfied. So then we took a Wolverine cutting balloon 3.5 into 10 and then dilated the mid and proximal lesions. and the balloon expanded well. So we knew that the stent will also expand well after this. So then actually the lesion length was around 60 millimeter. So we decided to take 2 stents. Then again here the stent could not be delivered. After having so much lesion preparation, still we could not track the stent. So then again we had to take a guide liner, and through that we could deliver the distal stent. So 3.5 into 38 was implanted in the distal RCA. And then Zions era 3.5 into 23 was overlapped in the proximal RCA, and stenting was done. So after that, again, OCT was run was done. We could see some residual still in the mid lesion where there were 2 calcific nodules, but the MLA was around 8. The expansion was only 31%. So, and at the proximal edge, you can see there was malapposition of the stent. So we knew we had to do more work. So then we took up a 4 millimeter 4 into 15 NC balloon, and then went at high pressures both in the mid RCA and in the proximal RCA, and in the ostial RCA. Flaring up was done with this 4 into 15. But by the time it was almost 4 hours since we started this procedure. So then we didn't do a final OCT run, but this was the final angio. And by the time patient became stable, his hemodynamics were stable, chest pain was relieved, the patient was fine. The long sheath was changed to a short sheath, and patient shifted to CCU.
Sir, really nice case, and there are some important points to be discussed. And see, generally, this is not a common scenario where we use both rota and orbital. So, what was your thinking behind that,
Oh,
sir?
I was thinking this also. So even previous day at NIC, I was discussing about this case. I had asked them that has anyone so far used rotablation followed by orbital atherectomy? They said no. Then I thought, see, if after the calcium was so heavy, even after doing rota, I would just create a narrow 1 millimeter space inside, but I will not be able to take a IVL balloon inside that. So then I need little more space. So that's what in fact, I had given the patient estimate for all 3. Even IVL I had given. In case after rotablation also, if I'm not able to get good lumen, I might use IVL also. So I mean, definitely the amount of calcium without orbital atherectomy, I would not have gained a lumen area increase, which I could get with this orbital. So that's why I thought orbital should be.
Okay. So why don't you try orbital directly without rota?
I was worried it should not get stuck. See, even crossing the wire itself was very difficult for me. Microcatheter would not cause. Retrospectively, I thought maybe we could have tried, but I didn't want to take a risk. I didn't want to get caught after crossing the lesion. So I thought better create a good space for the orbital and then take the orbital. Maybe it could have worked also if I had taken the directly.
We have done few cases where with orbital, where you couldn't cross microcatheter, balloon non-crossable lesions. Even although it is said that if it's a balloon non-crossable lesion, rota probably is the first choice. That is correct. But we have an experience where even with orbital, we can cross. But only thing is, there is a caution. Sometimes if that nose cone doesn't go inside the lesion, we may not cross.
Yeah.
So probably these are some things. But anyhow, is a rich patient affordable? So you probably 2 devices should not be a problem. But generally, what we have done is, if the orbital doesn't cross, we have used lacing there to produce some track, or sometimes we put only a small balloon there so that the nose cone goes inside the lesion and use orbital. Those things we have done. But it's a nice case, sir. And similarly, your imaging, the last OCT may not be needed because you already saw an OCT, and then there was some malapposition, only that you have corrected. And as you rightly said, in severe, so much of severe calcium and nodular calcium, to get such good expansion, you need some device like this, orbital or rota, or probably we use laser if it is available. So with this, I think we get good results. But one more thing is, after orbital and laser, do you routinely use cutting balloon? Because our
Most of the
thinking
times.
because our thinking is once you use these atherectomy devices, the plaque and the calcium become softer. If you put an NC itself, it expands.
Expand.
So probably if you had tried NC, it would have expanded. So these are some small bit. There will be a difference in style of practice. Only for discussion, I'm just bringing it there.
I mean, I somehow got used to it. Like after atherectomy, maybe in 60% of the cases, I still use a cutting balloon. 40% where I feel NC will do, I go with the NC. But otherwise,
No, my thinking is cutting balloon is probably if there is significant like fibrotic lesion, thick lesions, the blade will help. If it's a calcium, how is it going to help? Probably it is going to cut the normal area and then expand. But for a calcium, you need a very high pressure balloons, like NC balloon usually is sufficient. It's only a discussion, probably.
yeah, if the calcium has well broken, then definitely NC will do the job.
Yeah. Sampath ji, I saw you. Any other comments from you? Sampath, Adarsh, anybody else there?
Sir, the choice of guide, sir, you had used.
Better to take a support. You need a good supporting guide catheter for doing atherectomy, and it should be coaxial. So I took a SAL. If I took Amplatz, it will be projecting in too much. The calcium nodule was very near the ostium. So that is why I took a short Amplatz, 0.75 guiding catheter.
Yeah, and your guide plus, you could have taken it right from the beginning itself.
Yeah.
Probably microcatheter would have crossed, we don't know.
We tried. I didn't show that. For crossing the microcatheter also we tried. Then same only we used later on.
Fine, sir. Any other comments? Sampath, you want to add something?
It was a wonderful case, and so many learning points. I have never seen a case with both rota and orbital done in a same patient. But I would have tried if orbital was available, I would have tried orbital straight away first. And as you said, our center has laser. That is one additional option. But SAL and usually AL1, is there so much difference, Dr. Alilan? AL would have given a better support, isn't it?
Yeah, support, I think both will, maybe AL a little marginally better because it is more deep inside the coronary. But since the lesion is there proximally, we don't want that to go and hit the lesion or go inside the lesion. So that is why we took ASL. We didn't mind a little lesser support, but we didn't want the catheter to hit at the lesion.
Anyway, very nice case, sir. Very nice leader.
Thank you.
I think if there are no other points, Sampath, you can start your presentation. I think you are the second presenter.
Thank you.
Yes.
Correct. Wait a minute. Trying to share. Where is the share screen? I'm not seeing my share screen.
The green button.
usually it comes here, it's not coming.
Tech people, can you help him out? Tech. You are presenting from phone, huh?
Yes.
Yes, I think probably that's why you will have to see where it is. Share screen or.
Wait a minute, I'm going into that.
Sir, Elilan, sir, until.
Okay, next presenter, can you present? I'll come back later. I'll come through the laptop.
Yeah. So is Dr. Mahadevan there? I don't see him here. I could see Vijin. Vijin?
Yes, sir. I'm here.
Yeah. Good morning, Vijin.
Good
I
morning,
think
sir.
you can start your presentation by the time the other speakers get ready.
Yes, sir. Sure.
Yeah. So Vijin, introduce yourself. No, you are from?
Sir, I'm Dr. Vijin Joseph. I am from Lisi Hospital, working as a consultant from 2020, sir.
Oh,
I
very good.
did my DNB in 2017 from Lisi Hospital itself and continued there itself.
Yeah, okay. Okay, nice, Vijin. We'll like to hear from you. Please go ahead.
Is it visible, sir, now?
Yeah, we can see it. Yes.
So my case is a orbital atherectomy in a calcified vessel. So this is a story of a 80-year-old male who is a long-term diabetic for 10 years, presented with ACS NSTEMI with acute LV failure, and ECG showed a left bundle branch block with QRS 140 millisecond, and echo showed a global hypokinesia with a severe LV systolic dysfunction of E of 28%. So he was stabilized with our optimal medical therapies and IV diuretics and IV. And once he was stabilized, his hemoglobin was 12, creatinine was 1, and decided to take him for an angio. So the angio showed left main normal with a circumflex proximal 40% lesion, an LAD a type 3 with a mid 70% lesion, and a large diagonal which has again proximal 50% and distal 70% lesion with multiple branches from that diagonal. And RCA, a dominant vessel, more than 3.5 mm size, a mid hazy lesion, tight lesion, 90% lesion with underlying calcium. And distal also a 70% lesion with PDA, again 60% lesion. So from this angio, this patient is having a double vessel disease with LV dysfunction. Most likely the culprit lesion here, it will be the right coronary artery, especially the mid RCA when there is a hazy lesion there. So initially he was decided to undergo a multi-vessel PCI. First the right coronary artery, and then see the LAD based on a physiology study, and then do a complete revascularization if the LAD is positive. Why LAD was also considered? Because he is having an LV dysfunction with an LBBB of 140 millisecond. So first fix the ischemic part and then see whether the LV will recover or not. If it is not recovering, he might require a CRT in the future. Because of the low EF, he was also considered for a MCS support, which we had that time was IABP. So with IABP and under imaging, we went ahead with the PTCA. So initially a JR catheter was used and BMW wire was crossed and an OCT image was done. So I'll go to the still image here. When you see the OCT image at the area of interest, that is the mid RCA, you can see the tightest MLA is 1.1 millimeter square. And you can see a mixture of eruptive calcific nodule as well as nodular calcium. So this is the eruptive calcific nodule, and opposite to that is the nodular calcium. So now we got the underlying etiology on that hazy lesion. And if you see the proximal and the distal vessels, the EL to EL is around 4.3. So it's a very large vessel. So based on these findings, the options were whether to go ahead with NC, our conventional NC balloon, or high pressure OPN balloon or cutting balloon. The only problem here is when you use this balloon, when you have an eccentric nodular calcium, you might get an expansion towards the opposite side more. And towards the nodular calcium, you won't get an expansion, good expansion. So the second option was to go ahead with intravascular lithotripsy. That was a good option because if we could cross the imaging catheter, which has a crossing profile of 1 millimeter square, then our IVL should cross. Again, IVL, the shock wave should directly fall at the tip of the nodular calcium to get a good crack. Otherwise, sometimes the crack will be mostly on the basal part of the nodular calcium, where we won't get a significant cracks on the nodular calcium. The third option was go with the rotational atherectomy. Again, rotational atherectomy, it is wire biased, so you can get sometimes crack on nodular or sometimes crack on the eruptive calcific nodule. The another option was orbital, where because it was a large vessel, a 360-degree cut you can get with the diamond thing when you burr. Especially the sanding will do the sanding both in the eruptive calcific nodule and in the nodular calcium, as both are on the opposite side. So in this case, OA was considered because of this finding. So the 1.25 millimeter OA, we did initially with the 80,000 run and then increased to 120,000 run. Multiple runs was taken in the mid RCA. And after that, again, an imaging was done to see what the orbital has done to do the mid RCA. So initially the MLA was 1.1, which was now increased to 2.1 from the orbital. So if you see the still images here, there is sanding on both the sides. There is sanding on the eruptive calcific nodule area, as well as there is the sanding on the nodular calcium. So both the areas got sanded here, and the MLA is not actually 2.1 because now it is oval in shape. So it is actually more than 2.1 millimeter square. After that, because the EL to EL was 4.3, an NC balloon of 3.512 was taken, dilated at normal pressure, and you can see there is no dog bone effect there. The balloon was well expanded in the mid RCA. Just to confirm what the NC balloon has done the job in the mid RCA, the OCT was done again, and it showed that the mid RCA part MLA is now 4.57 millimeter square. Am I audible, sir?
Yeah, you're audible.
My PowerPoint got stuck. Sorry. So here the NC balloon has done multiple cracks, and now the MLA has increased to 4.5. So here multiple cracks we could get after the NC balloon. And then later, the distal part of the RCA was also checked here in the initial run itself. And here you can see the distal part of the RCA, the MLA is around 2.5. Here the finding is predominantly a fibrocalcific. The calcium is actually superficial calcium, not very thick, and thin plates are there. So here orbital, it's not required. When you have a thin superficial calcium, or conventional NC balloon can open this type of calcium. So here only NC balloon was used to crack this calcium. And it was pre-dilated with 3.512, and with the help of guide extension catheter, the distal stent was taken, deployed 3.5 into 23 sines Sierra, and in the mid part 3.5 into 33 sines was deployed. And post-dilated with 3.5 into 8 and 3.75 into 12. And this is the final result for RCA. PDA, which had a 60% lesion, was left because it was a TIMI 3 flow, and we got a good result in the RCA. Now, the final OCT run in the RCA showed a good expansion with an MSA. Almost in everywhere, we got the expansion is between 8 to 11 millimeter square. So it is a well expanded stent. And now when to the left side, FFR to LAD was done with IV adenosine, and the FFR is 0.77. Decided to do an image and see, because there was calcium in the mid LAD there. So from the imaging, we can see the tightest MLA is around 2.52 millimeter square. And from the still images, you can see it is a circumferential superficial thick calcium. The thickness of the calcium is around 1.03 millimeter. So in this type of superficial thick calcium, NC balloon we can try, and with the 2.75 into 12 mm NC balloon, initially there was a dog bone effect, but later on at high pressure the calcium got cracked. Then it was stented with 3 into 18 and post-dilated with 3.25 into 8 mm NC balloon. And this was the final OCT run in the LAD to see what has happened in the MSA. You can see in the area of interest, the tightest MLA, which was initially 2.5, now the MSA is 4.38 millimeter square. And the MSA, most of the area we got an MSA of 5, but at one point the MSA was 4.1. So that point again it was dilated with 3.5 into 8 millimeter NC balloon. So this was the pre-echo initially to start, and after 1 month LV has almost improved to near normal LV function after 1 month. So my conclusion here intravascular imaging, especially OCT, was preferred over IVUS because OCT plays an important role in identifying the underlying etiology, especially when you have an eruptive calcific nodule and nodular calcium. And orbital atherectomy helps in sanding for calcium modification, because here there was a mixture of nodular calcium and eruptive calcific nodule. This helps to give a better luminal area. And in circumferential superficial thick calcium, NC balloon or high pressure balloon or cutting balloon is good enough to prepare the vessel bed. Thank you.
Yeah, thank you. Nice presentation, Dr. Vipin. Elilan sir and Pankaj, you can just have some discussion, whatever you have.
Very good case, Dr. Vijay Joseph. I mean, your decision to take an MCS IABP support because of bad LV was well thought of. Definitely it would help in case you had landed up in a complication. And identifying the eruptive nodule and nodular calcium, and then taking the right orbital atherectomy to ablate, all that was well done. And for the LA deletion, the only thing is maybe I would have done with a cutting balloon, the mid LA deletion, and then stented it. That is the only way I would have done different. Otherwise, very well done case.
Pankaj, any comments from you, Dr. Pankaj?
Yeah, actually, nicely done, sir. Case young blood. I think they are doing really a good job.
Yeah.
And I appreciate that he has taken proper MCS support and done a proper bed preparation. And I think the result was very good. So I don't have much comment to do. I think you have done a very good thing to justify your case.
Yes, a very good case, good demonstration. So you said the patient is sick, LV is down, and then he had pulmonary edema. How comfortable are you using OCT? Do you use OCT in all such cases, or do you have any other options for that? What care do you take about it?
In this case, even though the LV was bad, after the good diuretic therapy, this patient was comfortable. So I had a backup plan of IVUS also, along with the OCT, because he was able to lie down properly. That's the reason I initially took OCT, and even his creatinine was also on the normal side. And he tolerated the entire procedure. As a backup, because of the LV dysfunction, I've added the intra-aortic balloon pump.
Yeah. Okay. So there is
But
Sagar,
when
I
you
think,
have nodular calcium, to measure the thickness of the calcium, I feel OCT will show much better than IVUS. That is the main reason I selected OCT here.
yeah, very good, very nice demonstration, Vipin. And I think
Thank you,
Sampath
sir.
is ready. We will go to the next presentation. Thank you so much for a good presentation.
Thank you, sir.
Sampath?
Thank you, Dr. Selvamani. Can you hear me now?
Yeah, we can hear you and see you. You're looking handsome.
As always. Less than you only, actually. You are the smartest.
Arish. Come on, go ahead, Sampathji.
Yeah. Straight away, take home message. Yeah. Okay. Thank you for the wonderful opportunity, and thank you, Dr. Selvamani. I'm just going to talk about my little experience about laser, which we acquired a few months back, around 10, 11 months back. And in a simple sentence, I can say that laser is like our Kaundamuni is Alinal Alagaraja. It is possible to do every complex case, almost every complex case, with the guidance of laser. And laser is, it's again an atherectomy device designed to cross, prepare, and treat the most complex coronary lesions. The machine looks like this only. It's a very sleek, small machine, smaller than a echo machine. And the
make it full screen. No, make it full screen. Is it difficult?
Yeah. Okay.
Yeah.
The machine is very small, sleek. The connections are so simple. You can set up the machine in 1 or 2 minutes itself. It's just a plug-in system, and it has a touch screen to change the settings and adjust the machine. And it is transferable. You can transfer to one room to another room, one hospital to another hospital. It's a very easily manageable device. And it acts by 3 mechanisms: photochemical. By breaking the molecular bonds, it can reduce the tissue. It can modify the plaque. Photothermal, where it forms bubbles because of vaporization of the intracellular water, and the bubbles ultimately lead to cell rupture. And photokinetic or photomechanical, where larger bubbles produce a thermal mechanism breaking the plaque tissue. And the remaining debris will be less than 10 microns in diameter, and it will be engulfed by the reticuloendothelial system. Thereby, distal embolization is very much prevented. And the screen looks like this only, and you can adjust the setting. And it is available in the laser catheter is available in two
two versions, 0.9 mm and 1.4 mm. 0.9 mm catheter is compatible with 6F guiding. 1.4 mm it's preferable to take in a 7F guiding. And it's over a 0.14 wire. The beauty of this laser is it can be taken up over any coronary guide wire. Unlike rota or orbital where you need a special guide wire, this can be taken up over any 0.014 wire. So you need not struggle to change the wire, try to put a microcatheter and remove the wire and put a rota wire. This you can directly pass over any rota wire, just like any coronary guide wire, just like a coronary balloon. It has multiple indications. FDA has approved for many conditions. The best and the most important is the just like what Dr. Elilan was showing, balloon uncrossable and balloon undilatable lesions. Wire crossed, but balloon could not cross. Balloon could not dilate properly. That's where the laser is very much useful, and it is useful in ISRs. Another important indication where ISR laser will be very useful, and long lesions, moderately calcified lesions. In CTO also, we can use just doing some lacing over that CTO place will soften the proximal cap, and we can enter the lesion with a CTO wire. It's useful there. Apart from this FDA approved indications, another important indication is an ACS, where heavily thrombosed lesions, the laser will be very useful. And this is one such case, diabetic 59-year-old male. 2021, we have done an RCA angioplasty, and now presented with angina, EF was 40%. As we can see, there are two significant lesions, proximal ISR around 70% and distal ISR around 90% in a long RCA stent. In ISR, it's very important to prepare the lesion. Preparation is the most important step in ISR. We have to debulk the tissue inside the stent, that new atherosclerotic tissue as much as possible, so that when you plan to put a next stent, there should not be too much sandwiching of that plaque between the two stents. So this laser vaporizes all the tissue and makes it more soft, and further pre-dilatation balloons will remove the tissue very easily. Another important use of this laser in an ISR is, suppose there is an underexpanded stent due to a calcium behind the stent. There are very limited options to expand the stent when there is calcium causing underexpansion of the stent. And laser and IVL are very useful here. Laser is actually slightly superior to IVL, I'll say. It delivers more energy, so you can, maybe there can be some breakage of the calcium behind the stent, but what it does mostly is it softens the peri-stent tissue. It makes it more flexible, so that when you dilate the stent, it moves the calcium away, so we can expand the stent better. So in ISR, this case we did lacing. So you can see that laser catheter is advancing, and we prepared the lesion, and this is how the third picture shows that blood vessel after the lacing. And we did an OCT. We could see good lumen gain and good clearance of the new atherosclerotic tissue. After that, we used Wolverine balloon to cut the tissue still further and expand that stent. And this is the post balloon OCT. and then stented with another long stent. And this is the final result after the stenting. And this is the OCT after the post dilatation of that second stent, and it showed a good expansion and good MSA, and the sandwiching of the tissue between the two stents was very minimal. There was good expansion, and we could get a very good result following in OCT. I mean, in the final OCT. This is another case, as I told you. In ACS, laser is very useful. It vaporizes the thrombus. Whenever there is a significant thrombus, it's very much useful, and in vaporizing that thrombus, so that no reflow or slow flow phenomenon is very much avoided. And I can say that probably by using a laser, we can clear the thrombus so much. When an OCT is done after that, probably we may be able to see the plaque morphology better than a usual thrombosection catheter. Because following the erosion 3 trial, we can say that if it is erosion, not plaque rupture, we may safely leave that patient without stenting. And one hurdle in that is the clearance of the thrombus by using the usual thrombus device. Many times we feel that we are not able to clear the thrombus properly, we not able to see the plaque morphology properly. Laser will be very much useful in removing most of the thrombus there, and we can study the morphology, and we can decide whether to stent the patient or we have left some patients without stenting itself. Stenting can be avoided in some patients where there is good clearance of the thrombus and not much of stenosis in the lesion after the lacing. And it is probably very useful when there is heavy thrombus burden, or if the patient landed in our cath lab after a significant time delay. 1 or 2 days later, the thrombus is very difficult to aspirate by simple catheters, so laser will be very useful there. This is one such case where you can see a tight thrombotic lesion in the medial AD, and already there is a slow flow in the medial AD, I mean the distal LAD. And we did laser there, and after the laser, we did a OCT imaging, and we could see that there is a plaque rupture around 6 o'clock position, and with a significant stenosis still there. And we stented it. We directly stented it. That is our current practice, that in ACS, when there is no major calcified or a severe fibrotic lesion, we directly stent it following laser. And this is the final result, where you can see that flow is very good, and there is no residual stenosis, and vessel is clean, and see the flow there, it's much better. TIMI3 flow is there. This is the final case, a 78-year-old male, hypertensive, recent inferior wall MI, RCA was totally blocked, and this is the LAD, a heavily calcified lesion in the proximal and medial AD, and this is the circumflex, again heavily calcified, a tight stenosis there. So after a few days of stabilization, we took him for angioplasty of the left system after dealing with the right system. And we first tried the circumflex, where we could cross the wire. Wire could cross the lesion in the circumflex, but we could not take any balloon across. We tried so many balloons, no balloon could cross the lesion. And we tried microcatheter also could not cross. So obviously no imaging catheter would cross. So the recommendation is to use a rota or probably orbital. But since we had laser, we tried laser. And we tried lacing with first saline lacing, then blood lacing, finally with contrast lacing ranging from 40-40 to 80-80, multiple runs. One good thing is about this laser is it can be done over any number of time. Unlike orbital where we can use only for 5 minutes or 5 minutes run, this can be done with over so many runs. And laser could cross almost 3/4 of the lesion. The final 1/3 it couldn't cross. But this time, now the balloon could cross because laser has softened that lesion, softened that calcium and the calcium area. Now a balloon could cross and we could dilate that lesion throughout the whole proximal to mid LCX. And after that, we did a OCT. OCT showed a severely concentric calcified lesion and with probably a nodule in one place. And we pre-dilated furthermore, and with the help of a microcatheter, we could deliver a 3.5 into 23 mm Zine stent and post-dilated with a 4 mm balloon. And this was the final result, and the final OCT also showed a very good stent expansion and a good MSA, and that was the OCT. So to take home message is laser can help in most of the complex cases, and including ISR, heavily thrombotic lesions, balloon uncrossable lesions, and calcified coronary lesions also. It needs caution during contrast lacing, more experience, more expertise, and cost is also a issue, but I think it's slightly cheaper than an orbital or an IVL. So laser is one thing which is coming up very fast, and I believe it's a very wonderful tool in treatment of in the PTCA of complex lesions. Thank you.
Yeah, nice case, Dr. Sampath, sir. Very good experience you have shown. And I think the general population, they are getting attracted with this laser so much that somebody in the social media I was seeing, they're sharing. So people think that laser is now replacement for the angioplasty. So people get attracted. I think your patient acceptance must be very high when you say that you want to do laser or something like that. So they accept it.
Yeah, when we started this program, when we talked to the management, we said, at least for the marketing purpose, you buy laser. People are very much they like laser because of that laser eye surgeries, laser stone surgeries. So if you say laser is available and it is possible to do angioplasty with laser, people will be very much interested and we will get more patients. That's what, and definitely people are fascinated by that fact. And you say laser, the acceptance is.
The Times of India, one article was published actually on laser therapies available in India. And that is actually written by some of the doctors in Delhi, actually, all our famous cardiologists and surgeons. And that article is getting circulated in the media, in the WhatsApp and everywhere, particularly general physicians, MBBS doctors, they are circulating to all the cardiologists and to the groups that laser is available now in India. So people are fascinated with laser. And of course, as a cardiologist, we also got very much fascinated with the presentation, what you have shown. And I think the most beautiful idea which I liked is no need to change any wire. And you can do as many times and you did not wait for the when you do the lasing. So I think that is the drawbacks what present atherectomies and has. The only my question is, do you have any comparison studies of laser versus IVL versus rotational atherectomies?
Regarding
yes, Sampath, go ahead, Sampath.
Regarding the atherectomy devices and laser, there is no direct comparison, and it is in many cases, not many, some cases you need to do both. Sometimes laser may not be enough, but we need to rotablate and then take a laser and do that. We have done some cases. Similarly, we have done some cases where we have done laser plus IVL also. But there is no direct comparison. But there is a comparison between the energy delivered by an IVL and a laser. See, there are three types of lacing. With a saline lacing, the energy delivered is around 20 bars. They say 20 bars. With a blood lacing, it is 50 bars with the laser, which is equal to IVL. And the third type of lacing, the contrast lacing, the energy delivered is 120 bars. It's double the time of IVL. So the energy delivered by a contrast lacing is superior to IVL. That's all there is available. There is no direct head-to-head
There
comparison.
is a recently published studies there, sir, by called as roller coaster trial actually.
Yeah, that is what I wanted to say.
Yeah, so
please
they
go ahead,
have
Pankaj.
compared three rotational atherectomy, IVL, and the
Laser.
laser. So they say that there is not much difference between them, and almost IVL, and they achieve. The only thing is that device success is more with the laser, because laser could deliver it better across the lesion. IVL, as we know that it is a balloon-based thing and little bulky, so sometimes you are not able to deliver across the critical stenosis calcified lesions. So you may have to take help of other atherectomy like orbital or something, or maybe combine rotatripsy or something like that. But almost the result in particularly this study is done in case of instant restenosis. And whatever the MLN is almost nearly similar. What do you think, sir?
See, actually, there are some 3-4 studies which they compared all this rota, IVL, and laser. Initial comparison trials in the laser segment, they did not use contrast lacing. So the effect was really not so positive. But with this roller coaster and other newer studies which are coming, we have an evidence of this calcium contrast lacing, which has definitely revolutionized the use of lacing, especially for calcified lesions. So other lesions you forget, severe ISR, fibrotic lesion, osteal lesion, thrombotic lesion. It is definitely better than whatever tool you have, whatever balloon, thrombosection. There is no doubt at all. So that segment, laser is good. But we had a problem with calcium because everybody thought calcium laser doesn't work. But now by usage of contrast lacing in selective, even in native cases where there is significant calcium, especially this roller coaster, and there's one more trial which I'm unable to recollect. So they have shown that it is at par with IVL or superior to IVL. So that is what is coming up. And our experience, more than the study, what we have been doing is we have been using it for severely calcified lesion also with excellent results, like when you use contrast. But only caution is you need to be careful to prevent perforations. You should know how to deliver, where to deliver, how much contrast to give. If you know that, you can achieve a very good result with lacing.
Selvam, have you seen any perforation with laser so far?
One case where I was doing an acute MI thrombotic lesion, and our sister accidentally injected contrast to see the image. So see, many times how we work is I'll be the main operator. There'll be a staff nurse who is assisting us. So it was probably the third case in the very beginning that where I was doing an acute MI accidental injection of contrast. The power became more. But it was there almost contained rupture. Nothing happened. There was no pericardial effusion. It was a contained rupture. And OCT showed how a rupture with laser looks also. We have those images also. But even today, almost 8-9 months, patient is doing well. But it was almost contained rupture. Apart from that, we never had any major issues so far.
Sir, when will you consider that 0.9 mm and 1.4 mm?
See, actually, there are 3 size catheters available now: 0.9, 1.4, and 1.72. So we have all these 3 catheters available. So usually, if it is a very big vessel, or if you feel that you need a better effect. So you go with a bigger catheter, 1.4 or 1.7. And so that, see how it is decided is the bubbles which the laser creates, the size of the bubble depends on the type of catheter you use. So if your catheter vessel is bigger, you should use a bigger catheter. That is what is recommended. But for almost 90% of the case, it's going to be a tight lumen and it's going to be severe thrombus or fibrotic lesion or a calcium with a narrowed lumen. 0.9 is sufficient. 1.4 and 1.7 rarely we use in big vessels like left main, very hostile LAD disease.
SVG graphs, I think.
Yeah, if we are not satisfied by the results with what we get by 0.9, we go use with 1.4 or 1.7. So the problem with bigger catheters is if you go that the crossing profile is difficult. So especially if it is a severely calcified lesion, you may not be able to cross with 1.4 or 1.7. So that is the reason 0.9 is recommended for almost most of the cases as of today.
Thank you, sir.
Yeah.
Can I
So,
present, sir?
yeah, any other points? Yes, sir.
Thank you, Sampath, for the night cases you showed.
Thank you, sir. Thank you, Selvam.
Yeah, thank you, Sampath ji. Thank you so much. I think our next presenter will be Dr. Mahadevan. I saw him here, Dr. Mahadevan.
Sir.
Yeah, yes, Mahadevan, sir.
Good morning, sir.
Sir, kindly introduce yourself, so that others will become familiar.
So I'm Dr. Mahadevan, sir, working as a senior intervention cardiologist at Kaveri Hospital, Vadapalani, sir. At present, sir.
Yeah.
Shall I proceed the presenting, sir?
Yeah, please go ahead.
Yes,
you can share your screen.
I think screen is visible, sir.
Yeah, we can see it. Make it presenting mode, full screen, please.
Now it's a presenting mode only, sir. Is it visible, sir?
Yeah, it is visible. Go to the dumbbell sign and press. Yeah.
Yes.
Now it is. Yeah, correct.
Yes. I'm here to present OCD guided bifurcation, left main bifurcation using a DK crush in acute ACS. We had a case of 68-year-old male, hypertensive, had an inferior LMI and had an arrest due to VT, which was reverted and lysed elsewhere and referred to our hospital. And during admission, patient was stable, hemodynamic stable, his pulse and BP were normal, and EF is around 55. And regional abdominal is present in inferior and infralateral wall of the LVs. This is the angiogram of the individual, which revealed is this is the angiogram of the individual. We done through the femoral approach, which showed dominant LCX with the homogeneous opacity occupying at the left main bifurcations and significant LAD stenosis and OM vessels. So since the patient acute setting and hemodynamic stable, we gave suspect it's a thrombus. We infused tirofiban for the patient and we waited and we want to know what exactly happening at the point of the time. So we do check angiogram which revealed same findings. There was no resolution of the opacity occupying at the bifurcation angle. So we want to know what exactly happening for the individual. Since patient is hemodynamic stable, we went through imaging with a special avoid. We wired both LCX as well as LAD using the Workhorse wire. Then we did a OCT run from left main to LAD. We want to know what is exactly happening at the bifurcation angle, and we also know how much amount of engulfment of the LAD ostium is there. This is a OCT run. OCT run predominantly showed fibrofatty lesions occupying the mid part of the LAD, and during the tightest left main region, there was a calcific nodule occupying and occluding the lumen. This is a calcific nodule at the bifurcation at the origin of the osteoproximal LAD, and the distribution of calcium is about 3 millimeter, and depth of the thickness of calcium is 1.4 millimeters, hugging the ostium of the LAD, that causing the luminal occlusion of these individuals. Then we wanted to pull back from the LCX. This is the OCT pullback from the LCX. This is the OCT image. This also showed more of fibrofatty lesions with the calcified nodule occupying at the ostium of the on the ostium. This is the ostium of the L6 adjusting the bifurcation angle. You can see the well-defined nodal calcified nodal, including the lumen of the things. And this is the still section. And the calcium distribution is 6 millimeter and depth is about 1.6 millimeter. So we wanted to have a calcium modification strategy. Initially, we used a cutting balloon. We dilated the L6 with the protrusion to the left main, also LED with a Wolverine cutting balloon. And this is the OCT run after the cutting balloon. But in spite we don't have any luminal gain, there is still persistence of calcium. This is the OCT run after cutting balloon. So this is the image. You can see minimal cuts at the level of 12 o'clock and minimal few cuts here and there, but it does not that much have an impact of luminal gain. So we wanted to do much more calcium modification. We used IVL at the point of times. And this is the IVL shots. We gave nearly 50 pulses was given at left main to LCX, because that is a major chunk of calcium occluding the lumen, and the calcium burden was very, very high at this angle. Then we moved to debulk the calciums at the left main to LED. Remaining 30 pulse was delivered. So this is a post OCT run. Little bit gain was there. Little bit the luminal gain was there. This is a OCT image. Pull back from L6 to left main. So here see many of the cuts was there because of the IVL. Much more luminal gain was there. So L6 ostium, the calcium modification was done to optimize our stenting procedures. So we had a luminal gain. We had a successful calcium debulking using IVL. And this is a post OCT run from LED to left main, because this is also a major vessel. This is also a OCT run of the individuals. So these also showed much more cuts occupying and much more luminal gain in terms of LED. So sizing, when you wanted to, we are both the size of the LED and L6 is near matching. So we wanted to optimize both the vessels. So L6 reference were about EL12 was 4 and LED was 3.8 and left main was 5. Since both the vessels are of equal caliber and angle is less than 70, we planned for a decay crash. So we follow the steps of the decay crash. So side branch was stented with the Zines 3.518 with a little protrusion to the left main. And the side stents was crushed with the using of a balloon. Then the side branch was rewired and the part was done. Then main branch was stented with the 3.5 into 28. And next, we had done a kissing balloon before stenting the main branch. That picture is not. This is a shoot after left main branch left main LED stenting, and side branch was stents was dilated for the second kissing. This is the part was done, and this is a shot. And this is the kissing balloon. We did the kissing balloon to 3.512 for LED and 3.512 for L6 simultaneously. And this is the final part we done. This is a, and then want to do what is the level, what is the stent approximation to assess the MSD and MLD to we planned the OCT pullback from left main to LED. This is the OCT run. We show a good expanded stent. There's no edge dissections. And there's no edge dissections. The stented area about 5.4. Ostial LED was also very good. Luminal gain was there, and left main area was phenomenally increased in these individuals. Then we had a pullback from L6 to LED. Which also showed no edge dissections, and the stent was approximate. There was no malapposition or undersizing. There was no any thrombus. You can see this is a no edge dissections. Areas MSA was around 5.1, and the L6 was 7, and the LED left main was normal. This is a 3D navigations, which clearly told there's a good apposition. There's no any tissue prolapse or a thrombus. So 3D navigations clearly eluded that stent was good in approximations. There was no any malapposition or under expansion of stents. So this is the bifurcation view of the 3D. You can see there are no much overcrowding of the stent studs or metal at the origin of the LCX. This is the final result we had after doing this. So we achieved TB3 flow without any compromise on the angles. This is the final result. So thank you. So you may, in the ACS settings, when you want to assess whether the thrombus or a calciums may present as an acute ACS settings. So in this bifurcations, because of the imaging, we are able to identify what is the exact pathophysiology happening at the level of the block and what modifications you can do, and approximation of a stent optimization and the future adverse events can be avoided if you do proper imaging and proper planning of the stenting strategies. So thank you, sir.
Yeah. Thank you, Mahadevan, sir. Very nice case and presentation. And it's over to you, Pankaj and Leland. You want to?
Yeah, very nicely done case, sir. And I could see in the final image, very nice neocarina was formed actually of the stented portion. The only thing is, what is the opinion of the all the panelists and chairperson? Now they are saying that the better technique is double kissing culotte, DK culotte. And because DK crush is, of course, Dr. Mahadevan, like expert, they can do in a better way. You have done excellent manner, but the problem is the crushing the stent and the unit shouldn't have little, it is a cumbersome procedure, as I think you may agree with me. And you have to cross the first wire from the proximal cell, and then after the deployment for doing a second kissing, you have to cross it from the distal cells. So that kind of knowledge should be there for every interventional cardiologist when you perform DK crush. So it is little cumbersome. It is very good procedure, and at present among all the bifurcation techniques, the most accepted technique is DK crush. Because whatever the studies and results, long-term results, they say that DK crush is one of the better stent. But while performing, I feel the DK culotte is more better. And there is one more new technique which I saw. It may not be much validated, but that is something called balloon-assisted T stenting. So double kiss balloon assisted T stenting, which was by Refray. It was published in Journal of Sky, and that also I did all these techniques, and among that I found that DK double kiss culotte is one of the most easiest way of performing it. So I want the opinion of the panel.
Yeah, Leland, sir.
I mean, the DK crush has evidence. It is the only technique which has scored over provisional stenting. So you have evidence. If DK crush is done properly, I think you get very good results. I don't have personal experience with the newer techniques Dr. Pankaj has said. So I'll not be able to comment on that. But I feel that you should master any one technique, and if you are mastering, I think it should be DK crush. Then it will become easier. Well done, Mahadevan. Nice case.
Yeah, nice case.
ACS was incredible.
Yeah. Only point for the discussion with Pankaj brought up. So see, actually, the DK crush is basically more of an Asian and a Chinese design, and there are Europeans. Nobody practices DK crush, and all Europeans they do culotte. And moreover, 90% of the Europeans they don't do two-stent strategy in the left main. That is one. But predominant left main two-stent strategies are done in our part, like China, Japan, and basically Asia Pacific region. And our experience with DK crush is more. But for people like where it is in the Europe, where they hardly do two-stent strategy for left main, the experience with DK crush is really less. That is one point. And when you compare studies, studies have so many limitations, but it is left to your discretion, like whichever you feel is good. And moreover, what Pankaj was saying is a balloon assisted T stenting. Those things are all very good. We also do that technique. What we call it is reverse T with
Reverse
protrusion.
T technique, yes.
That is called reverse T with protrusion. That depends if the angle is 90 degree or probably around more than 70 to 90 degree. This T protrusion is very, very useful because the amount of stent you crush is very less, unlike a DK crush. Problem with DK crush is you get a lot of metal crushed there, and then at the carina there is 3 layers of stent. Unlike Culotte where you have only 2, and with the T also we have only 2 layers of crushed stent. That is the advantage. But rightly said, evidence, experience, if you are familiar, probably that is the way you should go. And my personal preference is, especially ACS, although we do a lot of DK crush, I generally avoid DK crush in ACS or go for mini Culotte, but say mini crush or something with T with protrusion, so that your steps are less in ACS, your results will be better. That is my
Can in this case it would have been possible to put some kind of drug-coated balloon in the side branch and do a provisional stenting, something like that?
Yeah, that is my first preference today. How we practice is, we 90% try to avoid 2 stents in the left main, because whatever experience we have for the last 15 years and our follow-up, all problem occurs only when you put a stent in the circumflex. If you avoid it, I think we can compete with Lima also. From left main to LAD crossover, they do extremely well. Problem starts when you put a stent in the circ, probably at 3 down, 3 years or 5 years down, they come with some restenosis and we are having issues. So that's
Sir,
a very
but,
good option there.
will
You
it
can
help
always-
the drug-coated balloon in a nodular calcium like this?
Yeah, definitely. So there are, I could see as actually Chinese and Japanese, when I recently visited CCT, osteal RCA, there is nodule and they did atherectomy, and like Ellen sir's case, they did atherectomy and orbital atherectomy, and then they did drug-coated balloon to the case. Actually, I was surprised to see that in India, we don't have the daring actually to.
No, we have done few cases where osteal circumflex, after even orbital, we have left it with just drug-eluting balloon. See, in a calcific nodule, if it is, if you don't have an adequate lumen gain, putting a stent is more dangerous than DEB, because stent can create a lot of problems and then issues when there is an under expansion. And long-term results probably must be better when you don't put a stent. That is my individual personal opinion. It's left to discretion. And the Magadevan, in this type of bifurcations, why do you prefer OCT over IVUS? Any specific reasons? What do you think is better in bifurcation?
So IVUS can be better, sir. IVUS can be better, but OCT, I am more familiar with OCT because we are often doing OCT here. And another things, we can assess the more of the calcium modifications when you have nodal calciums. Morphology of calciums can be more related by OCT than IVUS at this bifurcation angles.
Magadevan, actually, for bifurcation, I feel OCT is the best compared to IVUS. Forget about other lesions and all, because there are no specific studies which have said that IVUS is better or something like that. But there are 2 trials. That one is this October trial, which we recently got. It's a specifically designed trial for OCT, which has shown that it is very superior. And if you identify unintended stent deformation, you will reduce the mortality by 28%. If you don't identify an unintended stent deformation, your mortality is going to be high. This is on the trial basis. And there is one study called ROC2 study, where they compared OCT IVUS in left main bifurcation, and they said the mortality or the long-term results are better with OCT compared to IVUS. So to be very specific, for bifurcation lesion, OCT is a better tool compared to IVUS. So that is one. So this is the fact as of today. And our experience also shows that, see, you can make out your results very clearly. You can make out where is the deformation. And at the same time, only thing is, except for the contrast load, I don't think there is any reason that you should not use OCT. IVUS, probably in some other lesion where you cannot do that, is a tool, but OCT is the ideal tool for bifurcation.
Yeah, the proximal strut crossing, distal strut crossing, and then how your side branch ostium is there, all that will be seen only by OCT.
And no study has shown that IVUS is better in bifurcation. And the ROC2 study is the only study where they have directly compared IVUS, OCT, and angiogram in bifurcation, and they have shown that OCT is the best. Next to that is IVUS, and of course, the question is only angio guided, image guided. You should do image guided. There is no doubt. And for bifurcation, probably OCT. And I think if there are no questions, we will have Dr. Pankaj to present his case, and I think we'll learn from you, Pankaj. It's over to you.
No, sir. Actually, I'm learning from all of you. So
No, it's
this,
all mutual learning, no mutual
yeah,
understanding.
definitely, sir.
Yes, yes.
So this is a case actually, again, another case of what we call ACS and calcium. So coronary calcium and STEMI, a trouble rubble. So something like that, which I gave the name. And this actually is a 82-year-old male, distant relative of mine. And his brother actually was my patient. So he called me in the midnight around 12 o'clock saying that his elder brother is having chest pain, radiating to back for last 4 hours. And there is risk factors of, he's a depressed guy. His wife recently died. And it is hypertensive. And this was ECG where he presented to our emergency room. And there was a severe ST depressions with atrial fibrillation. So echocardiography showed RWMA of posterolateral wall, moderate mitral regurgitation. There is a thick mitral annular calcification, atrial fibrillation, and Philip class 3 and positive troponin. So if you see very complex anatomy, and I took the patient for our primary angioplasty, and it was around midnight, by the time patient reached and I could stabilize the patient, it was around 2 o'clock, 3 o'clock in the midnight. And the circumflex is completely osteally, it is occluded, not able to see. LAD, left main, there is a very bad disease. Right coronary artery, there is a mid stenosis. Distal, there is a very significant stenosis. And all the lesions are heavily calcified. But in view of the instability of the patient and ST depressions, I thought we have to perform some kind of primary angioplasty. So with support guide wire parked in the LAD, and then workhorse guide wire was unable to cross, so I could use a Fielder FC wire, which could cross with some kind of difficulty. So I poked it with thinking that blind poking, where I thought the circumflex must be originating. And I could follow the calcium actually. We can see the calcium in the LCX, and that can be seen in the hair. And in this epicaudal, you can see there is some calcium along the circumflex. So the calcium could help me to point out where is the circumflex actually. And along that tram track or rail track appearance, I could pass my wire. So initially the normal balloons were unable to pass. So I have to go sequential dilatation, pre-dilatation using 2, 2.5 and 3 millimeter balloon. And then I could get some flow. And now the biggest thing is my OM optis marginal artery is very well open. Distally, there is very bad dissection. And there is something called in the distal, something like a perforation like thing is there. So I was little frightened at this point of time, but we did echo and we found that there is no pericardial effusion or collection. So all of them, they were non-flow limiting dissection, thrombus, distal minor branch localizing something like a perforation, and echo screening shows without any problem. So the patient was, so at this point, I did not stent this, and I thought I should bring this patient sometime later. And patient was converted to the sinus rhythm using intravenous amiodarone. And there is a non-invasive ventilation was continued because he was having acute left ventricular failure. Inotropic supports were given. Cardiothoracic surgeon's opinion was sought, but they denied for any coronary artery bypass surgery because of the high risk. So after 4 days of stabilization and discussion with family, we decided for a cheap PCI with standby IBP. And so this time the patient was relatively stable. What primary POBA, what we have done. And this time we thought, so that C2 balloon, C2 plus balloon, IVL balloon, we thought 8 pulses were distributed from LMC to LAD to circumflex. and everywhere we did IVL across the bifurcation, and these are some of the OCT images, and you can see there is a very thick, more than 5-6 millimeter thickness, and the entire it is like 360 degrees calcium, and the post IVL there is a breaking of the calcium, and this is the LMCA stenting, LAD crossover stenting was done, and so we did first LMCA to LAD crossover stenting with the using 2 stents, and this is a post-procedure image from the osteal LAD. There is a very well expanded stents post OCT, and then as we were discussing just now, we did a reverse tap technique across the circumflex, and the angle was good, preferable, and this is a kissing followed by repot, and again there was some dissection in the down into the distal part of the circumflex, so there also we did stenting. So total 4 stents were used, and patient we got very good result, and this patient has completed more than 1 year now, and it is basically a deferred stenting, what we call it as a primary POBA, is an alternative strategy in a complex calcified lesions, and CHIP PCI should be planned before the discharge in discussion with the heart team to reduce the MACE, and IVL was helpful in this case for simple and quicker debulking heavily calcified plaque in high-risk cases. So thank you for the allowing me to present this case, and
yes, Selilan sir.
Nice case, Dr. Pankaj. That deferred stenting was a very good option. Instead of trying to do complex things during ACS, you just open the artery, allow flow to happen, allow the patient to stabilize, and then taking him up for CHIP PCI really saved the patient and was a good strategy.
Yeah. Very nice, Pankaj sir. See, that is what the surgeon also does. See, when there is an acute MI, you establish flow, and if there is a complex left main, a LV dysfunction, ACS, generally they postpone the case for some time, stabilize, and then they take up for surgery. But unless the patient is having active chest pain and patient is becoming hemodynamically unstable, I think in a case scenario like this, it is better to postpone for a couple of days and then take him for procedure rather than doing the procedure immediately. But if it's a totally occluded vessel or if the patient is continuing to have angina deteriorating, then the story is different. And very nice presentation, sir. And that to use of IVL. And compared to other devices like Orbital or Rota, IVL, do you think is it really safe to use in acute coronary syndrome? What is your experience with this IVL, sir?
I think IVL should not be used when there is a lot of thrombosis there,
Yes.
actually. But in this case, actually, this is actually acute coronary syndrome presentation is also very important. So every acute coronary syndrome is not like a similar presentation. Here, basically, it is atherosclerotic disease. And if you are performing any imaging like OCT or something like that, where you think that there is a more or less like a calcified lesions, less of thrombus, already you have stabilized the patient, you have dethrombosed, you have given good antiplatelets, heparins. So I think in these cases, there is no other option, and IVL is a very good technique where your balloon passes very easily. It is like similar to like something like a predilatation use kind of balloon. So when we use IVL, actually in this case, it did not, the complexity what I had while doing primary angioplasty, it was so easy for performing this procedure. We were just doing the procedure, and whatever. The main thing is challenging was doing a left main angioplasty, bifurcation angioplasty. So when you have 2 challenges, like one calcium, another is a complex bifurcation of the left main, so you cannot struggle with one of the complexities. So one complexity has to become very easy so that you can tackle another complexity. So when you have both the complexities in your hand, I think the patient would have crashed.
Yeah,
So
sure.
I think because of the IVL, the lesion preparation, bed preparation becomes so easy so that you can perform the complex bifurcation angioplasty as you planned actually.
Yeah, yeah, but point well taken, sir. It's all depends on the patient. You cannot generalize everything. Probably in such a case, acute coronary syndrome, left main, you can have
Yeah.
high mortality if you are not very careful. And very nice presentation. Elilan, sir, you want to add anything more?
No, nothing, sir. No, like just as you said, in ACS generally we try to avoid doing rota, avoid doing IVL, but if situation demands, you have to do it.
Yeah, correct.
Sir,
So,
I have a
others,
question.
others,
Yes, sir. Sir, I have a question. I want to take you all a few years back, sir, like before all this IVL, Rota, and your orbital atherectomy, all this was available. So, have you ever, in your long experience where you don't have any other choice but other than a cutting balloon or a NC, and it is a very diffusely calcified vessel where you have stented and the patient is still doing good? Has it ever happened that way?
yeah, yes, others. There are anecdotal cases which we have followed. I still have one patient who probably it was in my beginning stages, like in my career, almost 20 years back, I think. I had a case, LV dysfunction. At that time, our awareness of calcium and then all these techniques was limited. Although I have been doing Rota from 2006 and 7, Rota was available, but this case which I'm telling you is before that, 2004 or something. And I had stented the LAD in the mid LAD, nicely calcified, but whatever balloon I tried at that time, it did not expand. So just we had no other option, just left him like that. The same patient came somewhere around probably 2-3 years back. We did a check angiogram. Vessel is still flowing, stent is still under expanded. But the problem is he had LV dysfunction at that time. Even now he has the same LV dysfunction. These are exceptional cases, but the probability they will have problems or stent thrombosis is very high. And we have had cases, we have taken up the cases, put a balloon there, it doesn't dilate. So once it doesn't dilate, we had to come back and send them to CABG. This was our scenario probably 25 years back. Now from 2006, I started using Rota. After Rota, we could tackle some cases, but not with so much of ease because at the time the guide catheters, there was no extension catheter. If there was a calcium, taking the balloon and stent inside the vessel used to be so difficult. We used to struggle like anything. But now you have extension catheter, Guide Plus, Guidezilla. It makes your job very, very easily. You can track it down very easily. And with the advent of imaging, so probably our thinking and all our plans are changed. Now it's a totally different scenario. We are able to tackle most of the calcified lesions.
Thank you, sir.
And I think if there are no other questions, we will call it a day. Thank you so much for being with us here. And we had a good interaction and learning from all of you. And it's over to the organizers. If somebody is there, Satish, somebody you want to talk something? Okay, I think they have gone into some live case. They are already working on that. I think we'll close the session here. Thank you so much, sir.
Thank you.
Bye, sir.
Thank you, sir.
Bye-bye.
Thank you, sir. Thanks for your valuable time. That too in spending your almost half a day in the Sunday, sir. Thank you so much for all of your valuable time sparing with us, sir. Thank you so much and knowledge.
Thank you.
Thank you, sir.
Naresh, we can close the meeting.